webinars, and if there's anybody, if there's anyone specific, any issue specific that you would like us to take, please raise your hand, and I will allow you all to talk. Hello. Yes, Mr. Jain, बोलिए. Yeah, Mr. Jain, please talk. Mr. Jain, you can speak. Okay, let me ask Mr. Dinesh Sagar to speak. Dinesh ji. Dinesh ji. दिनेश जी. हाँ जी, बोलिए.
I'm S.C. Jain.
हाँ Mr. Jain, बोलिए जी.
I would like that we have a program on alimentary canal problems. You can have in 2 or 3 stages, and that is one problem which mostly senior people do have. This is why my thinking.
Alimentary canal, all right. You know, I'm glad you pointed it out to me, because frankly speaking, we had not thought about it. So I will definitely. I'm making a note of it, and we'll try and have something. You know, may not be immediately, but we'll do something. Thank you, Mr. Jain, and thank you for always being there. Thank you, Mr. Dinesh Sagar. Sagar ji. Sagar ji, are you there? We have allowed you to talk. Is there anybody else who would like to speak? Who would like to offer suggestions? If not, suggestion of what we should tackle. You know, these views are very important for us, because yes, Mr. Paliwal, you can talk. Mr. Paliwal, you can talk.
Yeah. I think we should have a session on sleep, because most of us are suffering from this insomnia, and in various ways. It could be not able to sleep, or not able to continue sleeping.
Right. So Mr. Paliwal, I must tell you,
both of the aspects can be dealt with. And actually, this is a real problem, because there is hardly any sleep expert in India. Especially if you look at Mumbai, there's hardly one or two. This is one area which is not covered.
Allow me to respond to it, Mr. Paliwal. ऐसा है कि we've had 2 sessions on sleep already in the past, and we've had 2 sessions on sleep. We had Mr. Dr. Pinto and Dr. Punamia. So, you know, while we'll get somebody, I think sleep is an important issue. We will get somebody for sleep, but in the meantime, you can refer to these sessions on sleep that we have conducted in the past. You know, today, because Dr. Ojha hasn't come, I'm going to be a little caught up, but otherwise, we will try and send it to you also. Yeah, Dr. Mr. Paliwal, we'll try and send it to you. Apurva ji, Mr. Apurva Mehta, would you like to speak?
Can you hear me?
Yes, Mr. Mehta, boliye ji.
Okay.
So
my question is, I had requested you for contact number for one Dr. Gupta from 40s or Delhi. You know, he was pharmacology expert.
Right. I think we had, you know, what we do, I'll tell you, is that we are a little reluctant to share the numbers of anybody. So we had sent him your number, but I will send him a reminder once again.
That was for tele consultation. So
right. So no, I will you know, Dr. Rajiva Gupta. Yeah, I will do that today itself.
Thank you.
Yeah. All right. Mr. Koti? Mr. S.C. Koti? Mr. Dinesh Sagar?
Can you hear me?
Yes, Mr. Koti, we can hear you.
Yeah, the sessions are going very well and they are extremely useful. I must compliment you and the seniors today for organizing this.
Thank you.
And my only suggestion is, you could possibly consider having a session on these kind of a vaccinations. You see a lot of, advertisements by Amitabh Bachchan on shingles or, let's say flu vaccines. I mean, they are all expensive vaccines. Sometimes it may be necessary, sometimes it may not be necessary. Commercial interest, overtake in those advertisements.
Right.
So if you can consider, some specialist.
Surely, Mr. Koti, we've had some sessions in the past. We've had some internal medicine doctors as well. But, vaccinations and what you're rightly saying, shingles and the number of times you have to take the flu vaccine, all those things we've discussed in the past. But we will look at it again. What I would request, Mr. Koti, is if you can send me your email address on the chat, I will do one thing. I will send you the links to those sessions in 2-3 days' time. Mr. Koti, are you there? Dinesh Sagar ji, पूछिए आप, what is your view? What do you want to say? For those of you who have just come in, this is the Health Live at Seniors Today session. We are waiting for Dr. Pawan Ojha, but he has been pulled into an emergency. Naturally, an emergency is more important for him to be there. So, but he has left. He has sent a message that he will be with us in 10 minutes. So I would expect him to come join us by 5:15 for sure. Until then, please feel free. Shyam ji, boliye. Mr. Mittal, you can talk. Mr. Mittal? Mr. Mittal, you are on mute. Would you like to talk?
Yes. Good evening, sir.
Boli ji, good evening.
First of all, I would like to compliment the sessions which are going on. I have been regularly attending all these sessions.
Thank you.
One session I want is for Safed Motia. This eyes regarding eyes, there is a lens which is put into the seniors, which makes the visibility better.
Right. So we've had eye
conjunctivitis we had earlier.
Right. No, I agree with you. So I think we will have an eye specialist soon. I'm not very sure whether we will be able to have an eye specialist in the next 2 months, but we'll definitely have for sure.
Thank you, sir.
We like to do ailments concerning eyes, concerning ENT. We like to keep doing on a regular basis, and we will get somebody for that. Mini Gogia, will you speak with whatever you have?
Yes, like somebody just said about the eyes. So I thought we can have a session. You can have a session. Like I've seen people who are losing their eyesight gradually. They have some problem with their retina, which cannot be cured. It's an uncurable kind of a thing.
Right.
And youngsters are facing this kind of a problem. It's very disheartening. So, is there any way by which we can prevent or any cure available in the medical science?
So I'll tell you what. I must confess to you that we will be able to handle the issue. We will not be able to handle the issue for youngsters because we confine ourselves to senior citizens. But we will talk about this. We've discussed issues like glaucoma and the like. But this is something which is also important, and we will look at it. No problem.
I've seen a young girl, she's facing this kind of a problem. So it can happen at any age.
Really sad. Really sad. We've just got word that Dr. Ojha will join us in the next 2 minutes. I hope his patient is doing well. That's what we are looking for. Thank you, Miniji, for I think I've interacted with you for the first time. You're not very regular in these
I
sessions.
try to be regular, but sometimes due to some other work, I may miss the session, but I try to be regular.
You can always see what we are doing, even if you miss it. As I mentioned, we have we play we edit the video and we put it up on a Monday evening. And not only that, we also have a doctor who we have requested to transcribe, to give the salient features of the session. Shamala ji, you have a question? Shamala ji, you have a question? You want to say something?
Yes.
Yes.
Hello.
Yes.
This is regarding the bed sores people get when they are bedridden, and they get cankerous bed sores, and it is people don't know how to cope with that. And I would like to have a session where you people talk about how it can be coped.
Yeah, bed sores is an important issue. Even if even if you're not able to have a session on it, we will definitely have an article on the website on bed sores, because it's an important issue. I agree with you. Those of you who are here just now, please do subscribe to the Seniors Today website. We have a daily newsletter which goes out at 7 o'clock. Daily meaning Monday through Saturday, not Sundays. We have a newsletter, and there are even if I say it myself, there are very relevant and need-based articles that appear in it. We look at a lot of health issues. We look at a lot of relationship issues. So please subscribe to it. Subscription is without any cost, so you can just subscribe to it. The only thing is that it will come to you by email. We are soon going to be also looking at. Okay, so doctor has joined. I am just going to take off for a minute and see where he is. Doctor, are you here?
Hello. Yes, I'm here.
Yeah. Thank you, doctor. Doctor, how's your patient, first of all?
Yeah, it's stable now. Stable.
We feel sometimes so guilty, doctor, that we are pulling you from a patient. So whenever somebody says that they are attending to a patient, we understand how these things are.
Yes.
So, doctor, if you don't mind, shall we start?
Yeah, absolutely. Yes.
So, hello everyone, and welcome to Health Live at Seniors Today. We are delighted to have here with us Dr. Pawan Ojha. Dr. Ojha is a senior neurologist, and this session is being conducted on the eve of World Stroke Day, which falls tomorrow. It is October 29. I will take the liberty of introducing Dr. Ojha. Dr. Ojha is as I mentioned, a senior and well-known neurologist with experience of over 2 decades in the field. He completed his DM in neurology and a DNB in neurology through the Grant Medical College and the National Board of Examination, New Delhi. He ranked first in the DM and neurology examinations conducted by the University of Mumbai. He completed a fellowship program in stroke medicine under the Calgary Stroke Program at the University of Calgary in Canada. He is the president of the Neurological Clinical Research in India and the former secretary of the Maharashtra Association of Neurology. He is also a vice president of the Mumbai Stroke Society and an executive committee member of the Indian Stroke Association. His areas of expertise other than stroke treatment include headache management and vertigo treatment. And today we have got invited Dr. Ojha to talk about strokes and how to manage them. And thank you very much, Dr. Ojha, for being here.
Thank you so much, Mr. Maheshwari. So kind of you. I'm deeply humbled and honored to be a part of this, this whole program. And we definitely understand that stroke is important, and we will look into what are the basics and how what is stroke and how one can go to prevent or get proper treatment for it. So I will just share my slide screen.
Right.
Share my
What I
screen.
forgot to mention is that Dr. Ojha is with the Fortis Hiranandani Hospital in Navi Mumbai, and we are thankful to the Fortis team for facilitating this. Over to you, Dr. Ojha, and we've allowed you to share the presentation.
Yes.
And immediately after the presentation, as always, please post your questions in the Q&A tab. I will address these to Dr. Ojha as soon as he is done. Thank you.
So, yeah. So, I'm sure now my screen is visible and I'm also audible.
That's right. It is.
Yeah. So, uh, when we begin to talk about stroke, then we know that it is a brain disease. So, just like someone has a heart attack, which we now know as a myocardial infarction or MI in short, and we talk about emergency treatment. So, similarly, there are diseases of the brain and its blood supply, and it is called as a stroke. So, in common parlance, it is called as a hemiplegia, paralysis, or in Hindi Marathi lakwa. So, having understood that, it is different from what is called as a fits or a seizure or convulsion. So, when I discuss with people, then sometimes there is a confusion that stroke is the same as a fits, where someone falls and becomes unconscious and starts shaking hands and leg and uprooting of fibers. So just to clarify that, that is not stroke, that is called as a seizure or fits. So today when we talk about stroke, we are talking of a blood supply related problem to the brain, and that is also called as a paralysis. So this is the brain, and you see that there are various areas and various lobes. So this part in front is the frontal lobe. It is important for thinking, problem solving, speaking, and the hand and the leg control. So motor control. The area behind that, that is called as a parietal lobe in the brain. There is related relation to sensation. So if someone gets pricked on the finger, then the sensation will go up to this area, and this that sensation is decoded here. Similarly, above your ears, this area is called as a temporal lobe, and this is related to hearing and many other functions including face recognition. The back part of your head, it lodges the occipital cortex or the vision area of the brain. So what the eye sees, what the eye looks, this vision area sees. So there is a decoding of that vision here. Now all these sensations are interlinked with each other. So suppose these areas are being supplied by these arteries of the brain. Suppose one of the artery gets blocked here. Now no further supply will go into that area of the brain which is being supplied by that artery. Soon that area will be dead. So we have some time in between the blockage and the brain tissue dying. And we have to intervene during that time only. If you lose that time window, then that area is permanently damaged and there is a permanent disability and often a risk of death. Now that is not enough. Sometimes because we didn't identify the cause also, what caused this blockage, so there might be more strokes. Now, these more strokes means that in the next few months, there is roughly about a 25% chance of recurrence of stroke. And that recurrent stroke may also be a much larger one and may leave a person completely disabled. So suppose the artery which was blocked, it was this part, and the person will have like a right or left hand weakness, leg weakness, some part of sensory disturbances, so there will be numbness in that hand or leg also, but there may not be a problem with vision. Though other patients, suppose they're having a blockage in the back part of the artery, like here the brainstem arteries, then the vision and the balancing may go. So this is a small mnemonic which has been created to make us aware and remember all these types of various presentations of stroke. Now all the patients with stroke, they don't have only weakness of the arms or face or leg. Some patients who are having a stroke in this region, back part of the brain, they will have a problem with body balance. So if you saw someone who suddenly developed an inability to walk, right, that could be a stroke of this back part of the brain, that is at cerebellum or chota mendu. Now there is also a person who could have developed a stroke of this region that is related to the eyes. So the person may not be able to see with one eye or the other one, or the person may not be able to see all the objects in the visual field. So let's say that if the occipital cortex or the back part of the head suffers a stroke on one side of the brain, then the corresponding other side of the visual field will be affected. So if my this cortex is gone, I will not be able to see things on this other side of the room. That is also vision. Or sometimes the same eye can also become blind. So these two for the balance and the eyes. Now most of the strokes, they will eventually cause involvement of the face area or the arm area. So the face will look a little bit drooped here, or when you tell the person to raise both the hands like this, one arm will go down or may not be able to lift it also. Similar thing with the leg. And there will be some patients who will have problem with the speech area. So either there is a problem here or there is a problem over there. So around this river like thing, one bank, another bank, there may be a problem with the speech. So either there will be a difficulty in producing speech. So the person was able to work till now, he was working in office or whatever, and suddenly he's or she's unable to speak or unable to understand what you are saying. So that is a speech or a language difficulty. Now having recognized these symptoms, we have attributed them to the stroke. We will seek emergency opinion in a hospital which is nearby and stroke ready. So if you feel that the hospital of your choice is like 25 kilometers away and you would take more than 2 hours to reach that hospital in busy traffic, then it is a good idea to find out which one is the closer by hospital, which is a stroke ready hospital, and try to reach over there, because every minute is important. So a proper hospital should be reached where they are used to treating such patients. Right. So then we look at the blood supply of the brain and try to learn certain things. So the heart down here in the chest pushes blood supply up these blood vessels with every beat. Now let's have a situation where this artery is having a blockage. Suddenly that blockage has come. This artery was having a lot of cholesterol deposition, and suddenly this cholesterol deposition has become unstable and there is a huge clot inside. Now there is no more blood supply going up the brain in that particular area. So this artery is called as the carotid artery. And the branches of it which are supplying these various branches which are supplying various areas, one of them may be blocked with that clot. So, and resulting in all these areas getting damaged, and these some of these things getting manifested. So you reach the hospital. Now we should also understand that what will happen in the hospital. So there is a concept of a golden hour of stroke. So in the golden hour, we don't mean that it is only 1 hour. So typically in between 1.5 to 4.5 hours of the stroke, a treatment will be provided to the patient that will cause the reversal of the disease. Now, as soon as the patient reaches the emergency room, patient will be taken for either a CT scan or an MRI, and that scan will tell us which type of stroke this is. Whether this is a bleeding inside the brain, that is called as a hemorrhagic stroke, which looks all white inside, and even this here you can see, or you can see something not white but slightly grayish or blackish. This is the area of the damage to the brain because of the blood vessel getting blocked. Now all the other blood vessels in this region, they have been spared. Only one is blocked. That is why these areas are spared. Now we have done the imaging. We have identified that this is a ischemic type of stroke in which there is only a blockage and no rupture or bursting of the blood vessel. So what the doctors will do? So look at this blood supply of the brain. This is the internal carotid artery, this is the middle cerebral artery, and this is the anterior cerebral artery. This artery is supposed to look like this with its two branches and branches going up also. Here in this patient, there is a blockage from here onwards, and this arterial blood supply is not seen. Now, the aim of the whole treatment is to identify this blockage and to treat patient with these injections to restore the blood supply. This blockage should be cleared and it should look like this. So these are two injections. One was approved in 1996, another was approved in 2016. This injection is to be given after due diligence. It is given by a syringe pump over 1 hour duration. Slightly more meticulous method and takes time. And this one is a new medicine which can be given like a push. You just push it. So this new injection provides us the ability of giving the thrombolysis to patients while on the go. So you are after a CT scan, you are going to the ICU. From the CT scan, you can push the injection and take the patient to the ICU. Otherwise, the previous injection it was required, patient should be in the ICU, monitored well, 1 hour that syringe pump should function. So a little bit cumbersome, nevertheless. So we identify now patients based on the B fast. Now some patients will not have a stroke, but they will look like as if they are mimicking a stroke. Most important factor is of hypoglycemia. So a diabetic patient who has taken the injections or the tablet but not taken proper meals, then that time the sugar can go low and that can look like a weakness of one side of the body or whole body. There can be a altered sensorium. The patient may be drowsy. You may not be able to wake him up. So it's a good idea to do sugar testing if there is a glucometer at home. Usually a sugar of under 70 is taken as hypoglycemia and treatment should be given through glucose. Now this glucose is given by either IV method if the patient cannot swallow or the hypoglycemia is very severe, or orally when the hypoglycemia is very mild and the patient can swallow. Now there are many other conditions which can look like a stroke. We should not go into all that details. But there are a few occasions when the stroke will not have that manifestation of B fast. So it will be something different, some other presentation. So what are those other presentations which could also be stroke and we should be aware? So a person has suddenly a lot of vertigo, no problem with body balance, but only things spinning. Or there is a movement disorder. Movement disorder means suddenly there is an abnormal jerky movement in the hand or leg. or the person is suddenly confused. So then sensory abnormality. One can have just a pure numbness on one side, maybe face, cheek, hand, leg, or there is a acute amnesia. So a individual who keeps on asking, "Where am I? Who am I? Where am I going?" That is a acute amnesia. That could also be like due to a stroke. And shaking TI means there is a blood supply which becomes less for some time. Again, temporarily the artery opens up, so there can be limb shaking episodes. When the blood supply is less, the limb shakes vigorously, and when the blood supply is restored again automatically, then the shaking stops and the person is able to move the hand and leg. Now, let us say that we identified stroke and we have treated also, and then suppose there is still some deficit. Now there is still that the person is not able to move the hand or leg, and gradually there will be some associated stiffness in that hand or leg, and some physiotherapy is usually recommended. So good physiotherapists will be able to help the patient in many ways, but sometimes what happens, the area of damage is so great that there is not enough brain area to take those commands that is being generated by the physio. In these situations, we use this device. This is called as a transcranial magnetic stimulation device, TMS. It's a device which is used to stimulate the brain areas and to alter the response of the uninhibited areas. So there may be a lot of dysregulation in the brain. So this area of the brain which is looking white, that is not working, and sometimes the other opposite side area is not allowing this area to work further. So there is a double problem. So when you do this transcranial magnetic stimulation, you try to balance the inputs of the brain. Now when the age increases, then heart is also aging, and sometimes you get the stroke because the problem is in the heart. It is generating clots and it is throwing up to the brain. That clot gets lodged in the brain arteries and blocks them, leading to a stroke. So one must remember a condition called as a atrial fibrillation. Now normal ECG looks like a even ECG. So this PQRS, then TPQRST. Here what happens? This is not coming like regularly. The beat is not coming regularly. It is very irregular beat. So there are devices now. These are called as a patches. They can be applied on the chest wall. These devices will record for 3 to 7 days, sometimes even longer, to record this kind of activity. Suppose a regular ECG does not show it, but your doctor is suspecting that there may be a atrial fibrillation which is coming and going. So for that, these patches are very useful. You can put this patch, go home, and link it with the mobile device, and the doctor will get the readings. So why this is important to know about this atrial fibrillation as the age increases? Because normally what medicines we are taking, those blood thinners for preventing stroke or heart attack, that is everyone knows the aspirin, clopidogrel, they are gentle blood thinners. But if the stroke is because of this cardioembolic, means heart is generating clot and that is blocking the brain, then you need a much stronger blood thinner. These agents are called as a dabigatran, rivaroxaban, apixaban, and they thin the blood by more than 70%. So very effective, highly effective medicines for this atrial fibrillation. Now some people will also have a blockage in these neck arteries, so enough blood is not going up to the brain, or sometimes the cholesterol and the clot from here, whatever is generating, moves up and lodges in the brain arteries. So in this patient, if you identify that someone has a minor stroke and has a major blockage in the neck blood vessels, then it is a good idea to do an angioplasty and stenting. By angioplasty, what we mean, you put a wire and a catheter through the groin, through the leg arteries, go up in the chest, go up in the neck, and there you sort of try and open this using a stent, a balloon stent, and then keep a stent or a spring like stent which keeps the artery open. So these two things we must know. Now, how to prevent the strokes basically? So everyone knows that we can prevent the strokes by two ways. One is by doing lifestyle changes, and the second is by preventing the risk factors. Now, the risk factors of the stroke that are there, they are common to all the chronic diseases like heart attack or a kidney dysfunction. So that blood pressure is very important. So we try and keep the blood pressure to less than 125 by 75 if the patient has a minor stroke. Then your bad cholesterol should be kept less than 100. Triglycerides, hardly any people know about it. It should be less than 150. Another factor which we have not written, especially important in younger individuals, is called as a homocysteine. Now, homocysteine should be kept less than 15, and high HDL cholesterol, good cholesterol, should be kept more than 40. And it's very important to reduce the weight in those people who are overweight or obese. So these are the risk factors. Now we also want to know what are the lifestyle changes one must do. So one, the person who has had a stroke or one who is planning to not have a stroke in the lifetime should immediately stop smoking. There should be a good physical daily activity to the duration of 30 to 60 minutes. I suggest at least more than 45 minutes. And for an overweight or obese person, the weight reduction should be done. Now, in general, the plant-based diets, they are more useful, more healthier than the animal-based protein diets, and that is typically called as a Mediterranean diet. Now, Mediterranean diet has basically lots of fruits, vegetables, olive oil, and cheese, rather than, and sometimes fish also is included. But there is also another approach which is called as a dash diet, that is dietary approaches to stopping hypertension. So this basically is a low salt diet and some fruits and vegetables, they are recommended. Or simply we can have a vegetarian diet, but avoid too much of salt and oil, maybe rice, potato, all these things we must avoid. So green leafy vegetables and fruits. So the essence is that it should be a low salt, low oil diet, and as much as possible free of the animal protein if one wants to avoid the stroke. And it will also help you avoid the heart attacks also, as well as the uh, kidney diseases and many other chronic diseases. So dietary recommendations are that one must stop using saturated and trans fat and increase dietary fiber. Now if you look at this whole thing, then you see that whatever we are now in the habit of ordering food or going and eating outside, whatever you buy, the oil you buy at home, you choose and use. That means it is having this unsaturated fatty acids or the sunflower oil, safflower oil, rice bran oil. So those oils are not being used in the restaurants and in the low cost kitchens, cloud kitchens. They are using mainly palm oil, and that has a bad effect on all the arteries. So please avoid eating as much as outside. It is not right. It may be easy but not right. And reduce the intake of sugar sweetened beverages or the cokes and Pepsis and all those things. You must limit just for an occasion. And maybe moderate alcohol intake is all can be suggested to those people who can't stop alcohol intake, but that also means maximum of two pegs a day for 5 days a week, not every day, not like full quarter, and restrict the salt intake. So with this, I come to the end of the session, and these are my thoughts about how to go ahead with the preventing stroke, and if at all someone gets a stroke, how to treat it. So thank you so much for the kind attention, and I'm rather happy to have any questions.
Thank you very much. Thank you very much, Doctor. Your presentation was very detailed, and I think uh, we've answered most of the questions. For all of you over here who are watching, please do remember that the edited video of this session, along with the takeaways, which are written by a medical practitioner, will be up on the Seniors Today website on Monday evening. That is Monday the 30th. It will be there in the evening. You can look at that. In the meantime, I will raise some questions. There's a question from Kusum Jagtiani. She is 78. She had a stroke in 2015. Her question is, can you tell me, does the brain damage, is it permanent? And she is independent, only has walking problems and speech problems, inability to express herself completely.
Right. So this is a very, very important question, and it is never been answered really. The issue is that when we are born, that time our brain is developing, and gradually it develops till the age of 2 years. Till that time, the neurons are forming from their stem cells and all those things. And what you have at the age of 2 years, you are not going to have more neurons in the brain after that. Till the age of 20, these neurons are developing, they are getting more connections, right? So that connectivity, that speed of developing new connections and polishing those connections and putting them to new use is what causes us to learn certain things. Now, after 20, 25, 30 years of age, the neurons are not developing, new neurons are not coming. They are also not so agile to developing new connections. So if at all you lose a set of neurons in the brain because of a stroke, so there are no new neurons to compensate for that loss. So the surrounding areas of the brain which are around these regions which have been damaged, they try to learn those functions, they try to take over some function, but it is never as efficient because they have their own functions to do also. So it's like the now your accountant is not there, so you try to teach someone with a similar profile, but he is not basically an accountant, and he has his own job also. He is like the probably the HR guy also. So, and it becomes progressively more difficult at the age of 75, 78, because that is the time then these neurons are also wanting to retire, and you are wanting to teach them new things and efficiently. And maybe three, four guys are, pushing them, flogging them, the physiotherapist, the speech therapist, and everyone. And your family member is trying to tell you that do more exercise. So that is why that result may not be there, because they are near retirement. Now, if there is a person who is 20 years old and develops a similar stroke, the brain is in a learning mode and able to take on all the stress of the repeated exercise. So the outcomes may be different at the age of 20 versus at the age of 78. Right, but nevertheless, we should not stop all exercises and all that, because definitely they help in some way. There may not be complete recovery, but there may be a lot of compensation that can happen.
Right. Right. Thank you, Doctor. We have a couple of questions which are slightly similar. One is from an anonymous attendee who's 79. He's had diabetes type 2 for 15 plus years. Off late, he's been having a tingling sensation in the toes, perhaps. His question is, can this lead to stroke? There's another question from Mr. Satish Kalia, who's 78. He's diabetic for 12 years. He's had a tingling sensation in his left leg and foot. Given methyl cobalamin for the last 6 months, vitamin B12 is more than 2000 for the last 6 months. Feeling better without. Should I carry on with the medicine or stop it?
So let's say I'll take the second question first, because it's a simpler one. So going by the situation, if the tingling sensation is coming and going, or it is intermittent and it's not getting worse. then it is more likely to be a problem related to the peripheral nerve in the leg rather than in the brain. Right, so it can be a symptom of a diabetic neuropathy, and since it is an asymmetric neuropathy, so there can be a local issue also. So a good nerve conduction study will help us in understanding what is the reason. And B12 is okay, but B12 is not the cure for everything. So it's like if you have a deficiency of B12 and that is causing symptoms, then it is a good idea to keep on taking B12. So anyway, your B12 is high and it doesn't look like it's a case of B12 deficiency. So my suggestion is that a good clinical examination, maybe a nerve conduction study, and then a proper choice of a medication. Sometimes newer medicines are available. So that should be done rather than just continuing with B12.
Right.
And the first question is probably an extension of the same thing. So it is also probably looks like it's a case of a diabetic neuropathy, and there are now a lot of medicines to help repair the nerves also, and also to pacify the nerves which are crying with pain. So those things should be taken rather than taking a self medication with vitamins.
Right. Doctor, thank you. We have quite a few questions that have come in, but I'm going to avoid the question on vertigo. For that, we'll do a separate session later. There's a question from Katie Dadanchi who's asked, Doctor, is stroke hereditary? If one of our parents had it, what precautions can we take?
Yes. So, fortunately, not all strokes are hereditary, but there are a few indications in which strokes can be hereditary, especially the ones in which the strokes have come early in life. So let's say that someone doesn't have much of a cholesterol or much of a high homocysteine or blockages in the arteries of the neck, then you can have a disorders like CADASIL, which are basically hereditary strokes. The other hereditary stroke which I want everyone to know is something which I mentioned, that is related to homocysteine. Now we know about cholesterol, but hardly anyone knows about homocysteine. So everyone should get their homocysteine checked. Homocysteine runs in families. So suppose there is a mutation in the gene of MTHFR mutation, which can cause stroke. So I've had like four patients in one family, both parents, both children having strokes. At the age of the children is 22 to 25 years of age. So it can happen, but not all strokes. So maybe around let's say 90% of strokes are not hereditary. Only 10% are.
Right. Thank you, Doctor. We normally try and finish by around 45, but today we'll be there for another 10 minutes, Doctor, if you don't mind.
Yeah, I'm okay.
So this is a question from Mr. Kamlesh Vajpayee. He is 70. His BP remains high. Recently, his sodium was low. He had some tightness type feeling in the head. In angiography, no blocks. Doctor increased the salt. BP medicine changed. Now he feels better. From a neurological perspective, is it something to worry about? Stroke or whatever in future?
No. So I don't think that's the case, and I think just a low sodium can give rise to abnormal functioning of the brain and the body nerves, and so there can be these funny feelings, funny sensations. But what is reassuring is this doesn't lead to any stroke. It can lead to a seizure though. So seizure, as we discussed, fits. So please take care that build up the sodium and keep it high. So let
Right.
it be in the known range.
Doctor, there are two questions, different, but it's a differentiating. One is from Shamla Ravi, who asks, "Is stroke and TIA the same?" And Priyank Dave asks, what is the difference between hypoglycemia and stroke?"
Okay, so first is TIA and stroke. So basically, stroke is the movie and TIA is the trailer, right? So if you have a stroke-like symptoms like body balance and vision problem, or the face becoming droopy, or the hand becoming weak for let's say 5 minutes, 10 minutes, and then automatically you recover and become normal, and this happens 2 3 times in a day or 2-3 times in 2-3 days, then that would we will call it as a trailers. So that is TIA. So TIA is usually a warning symptom that one must take proper and urgent medical advice and start taking blood thinners to prevent any further stroke. And a stroke is a stroke. Stroke causes damage. It's like, these things happened to me and they lasted. They didn't disappear in 5 minutes. You didn't become all right in 5 minutes. It came and there was a steady and fixed deficit. So that is TIA and stroke. Now, hypoglycemia and stroke. So basically, what is hypoglycemia is when you have less sugar available to the brain. So the brain is a very like a electrically fast working organ, and it needs certain nutrients for its functioning. One of them being sodium, the other one being glucose, right? So the glucose, if it is not available, how the brain is going to function? So if there is a person who has diabetes, see normally hypoglycemia will not come to a person who is normal and not having diabetes, not on medication. If a person like a normal person is not eating, he is going to have very tiny hypoglycemia. He is going to feel slightly hungry and maybe slightly dizzy. So he will go for and search for food. But the hypoglycemia which happens to diabetics who have taken their medications or insulin and not taken food, the hypoglycemia sets in very fast, very deep. So they become weak, drowsy, they can't move, and sometimes they can have seizures, sometimes they can look like they have had paralysis. And one must be on the lookout for these symptoms to people, any person who is having diabetes and taking medication. And sugar should be made available to them right then and there. Otherwise, they have to reach the hospital and take IV injections of sugar. So I hope that answers the question.
Uh, Thank you, Doctor. Doctor, there are a couple of questions who are from our regular audience. They're not concerning stroke, but I'll
Yes.
still, if you can briefly just advise them. One is from Suresh Hate, who's 71. He's suffering from vertigo. He suffers from vertigo 2-3 times a year, and he wants some preventive measures. There's a question from Sunita Lawrence. She's not mentioned her age, but when she's walking, she feels like something is shaking her. I also experience jerks in my hands or legs before I fall asleep. Vertigo in mid sleep. Should I see a neurologist? She asks.
Okay, so one by one, so the jerks when you go to sleep is a normal common phenomenon. It is called hypnic jerks. If they wake you up in the midnight, like you get these jerks at the onset of the sleep, that is fine. But if you woke up with a jerk at like 3 a.m. suddenly and you are still jerking, then that is a cause of concern. The other thing is regarding the vertigo. The vertigo when you are walking and you suddenly you have this vertigo and you've been having like once in 3 months, 6 months kind of situation, maybe over the years, then it is a reassuring thing, that it will be nothing dangerous. So nothing dangerous will keep on coming and going at 3 month intervals. So it may be just be a problem with the balancing system of the ears. Now the ear balancing system will have to be evaluated. So you can first visit either a neurologist who has got a special interest in vertigo, or you can go to an ENT specialist who has an interest in vertigo, because it is on the fringe of both these specialties. So, but there may be a case that that you want to finish off doing that thing and be safe rather than be sorry.
Right. Thank you, doctor. There's one question is not concerning stroke, but an anonymous attendee says, my mother has suffered from a brain hemorrhage since last 5 years. Her left side is paralyzed. Her vision is affected. She tried physio and speech therapy, but in vain. She's also suffering from Parkinson's the last 10 years. Her question is that she's 84, her mother. Is there any chance that she can be cured? I know, doctor, this is a very tricky question to
Yeah,
ask you.
I know. So the issue is that as we discussed about this neuroplasticity, now this neuroplasticity or the repair function or the reorganization function is very poor at this age, right? So unfortunately, the answer is no, that she cannot be cured, but obviously she can be treated. So then you need to find out this, that even the diabetes cannot be cured. right? Blood pressure cannot be cured, but we take treatment for that, right? So it's a good idea to take treatment for two reasons. One is to improve the quality of life of the patient and the caregiver. So suppose the hand was very rigid and you are unable to do the cleaning also, or the leg, so you want to make it supple, and you want to make it better, that will lead to pain and spasms and all those things. So that, and also to prevent a second stroke, right? So both treatment and prevention.
Right. Thank you very much, Doctor, for taking session. I think most of the questions we've answered. A couple
Yes.
we haven't been able to, but that's all right. Doctor, thank you very much for taking time out. It was a pleasure to have Dr. Pawan Ojha, who is, as I mentioned, Director Neurology at the Fortis Hiranandani Hospital in Navi Mumbai, to take this session. As we are aware, he had an emergency patient who came in, and he's still here with us. Thank you very much, Doctor, for being there. We will be back again next Saturday. That is
Thank you.
November 4th. 4th is when we'll be back again for a session of health webinar. Remember, you can pre-register for our sessions. I must here make an announcement that on November 11th, that is a Saturday, we will not be having a session because this is the Diwali weekend. We don't want to discuss ailments, etc. So enjoy yourself. We will not be there on the November 11th. So November 4th, we have a session. November 11th, we do not have a session. And November 18th, we'll be back again. So just an advance notice. You can take your weekend off accordingly. You don't have to worry about missing out on a health webinar session. And thank you very much once again, Dr. Ojha, for being here.
Thank you. Thank you so much. Thank you.
Hospital for facilitating this. Remember, there's a host of things happening at Seniors today. You can download the Evergreen Club app. You can watch whatever is happening, read the magazine, check our website, subscribe to our newsletter, etc., etc. And this session, remember, will be there on the website on Monday evening. We have the 150 odd health webinars that we've had so far. You can also look at the archives and watch the videos on the health webinar tab.